So let's take a look at the next part of the peripheral system, the autonomic system. The autonomic nervous system is responsible for peripheral control to non-conscious response. This is going to be involved with the ability to regulate visceral function as well as response to stress stimulus through what's referred to as the hypothalamic pituitary adrenal axis, which we'll look at with the neuroendocrine response. We break it up into two divisions: the sympathetic division, which utilizes the sympathetic trunk, and the parasympathetic division, which utilizes peripheral ganglions. So if we start off by looking at the difference of the efferent pathways here. So at the very top, we look at the somatic motor pathway. Notice it's utilizing acetylcholine for its transmitter. And then we have our two divisions here. We have our sympathetic division, the next two parts, and then the parasympathetic division, the last image. Notice that the first of the neurons that we're going to see are going to be cholinergic neurons. Now, there's a kind of a funny thing that happens in terms of the sympathetic at the adrenal medulla, where you see the chromaffin cells. There's also norepinephrine neurons that are going to go to the chromaffin cells that are going to also be involved with the production of and release of epinephrine from the chromaffin cells. So even though acetylcholine is involved here, also noradrenaline or norepinephrine will be involved. So going from the spinal cord to what's referred to as the ganglion or the preganglionic neuron are all cholinergic neurons or acetylcholine. The next part of the pathway is known as the postganglionic. For the sympathetic side, it is what's referred to as an adrenergic pathway. So it's going to utilize norepinephrine or epinephrine. This is a much longer lasting pathway, and it's longer lasting because of the fact that the chromaffin cells are going to be releasing epinephrine and to a smaller extent norepinephrine into circulation to travel through the body. And we'll get into this aspect of it when we look at the neuroendocrine. On the parasympathetic side, it is strictly cholinergic, both preganglionic as well as postganglionic. And this difference of transmitter is why we see a difference in response. So once again, we're looking at the sympathetic side. So on the sympathetic side, we're going to have the acetylcholine to start with. Now, notice that we have two distinct pathways that can come out here. We have a noradrenergic pathway coming away from the ganglion, but we also have a cholinergic pathway, acetylcholine, coming out. This duality of signal is why the sympathetic nervous system has differential responses based off of what we see in the tissues. So what the sympathetic side can do is it can cause an increased response, an increased level of action potential within the tissues. However, at some cells, particularly within secretory cells, the acetylcholine triggers the response, whereas we see more of the adrenergic responses at peripheral tissues that need to reach action potentials in order to cause changes, such as within the smooth muscle of the lumen of the vasculature, or in terms of changing metabolism at distinct tissues. On the other side, we have the parasympathetic. And on the parasympathetic, we're going to be looking at strictly acetylcholine. So the strict acetylcholine on the parasympathetic side indicates that what we're going to see is we're going to see a change within the peripheral system that is going to be different from what we see with the sympathetic side, where we're going to reduce the rate at which we get depolarization taking place within the receptors. And this differential response that we see within the receptors is why we get relaxation on the parasympathetic side versus excitation with the sympathetic side. Now, what you saw on the previous slide, you may have noticed that there are two types of receptors indicated, nicotinic and muscarinic. On the sympathetic side, there's another receptor that was indicated as the adrenergic receptor. Now, all ganglion receptors are going to function on the nicotinic receptor. The nicotinic receptor is an ionotropic receptor, which means that when the molecule of acetylcholine binds onto the receptor, it's going to cause that receptor to open up an ion channel, which is going to allow for ions to move in, leading to a change of polarity. The muscarinic receptor and the adrenergic receptor act as metabotropic receptors, which means that they're going to trigger a cascade of events within the cell, which leads to eventually causing the depolarization to take place. Both the muscarinic as well as the adrenergic receptors are postganglionic, which means that they're actually at the peripheral tissue that's going to respond to the autonomic signals. So what we're looking at here is we're looking at the different types of receptors based off of what their structures are. So notice the muscarinic and the adrenergic receptors are both metabotropic, whereas the nicotinic receptor is ionotropic. Now, if you notice with the ionotropic, there's that central region within the receptor. When we bind onto, or when the cholinergic molecule binds onto that receptor, what it does is it causes those proteins to open up, to change their shape, causing a pore to open up that allows for ions to move in and out, leading to the change of polarity. Whereas on the muscarinic or the adrenergic receptor, what ends up happening is that we bind onto the extracellular part of the protein. That then causes a protein that's linked on the intracellular side to cause a cascade of events leading to the ultimate change that we see. And so we'll take a look at what each one of those will do here in a second. So in terms of actions on the muscarinic side and on the nicotinic side, so where are we going to see muscarinic? Well, we're going to see it in the ganglions of the glandular tissue, and we're going to see it within cardiac muscle. What we see in the glandular tissue leads to excitation. However, what we see in the cardiac muscle actually leads to inhibition. And it leads to inhibition by causing hyperpolarization of what's referred to as the nodal tissue. By causing hyperpolarization at the nodal, it causes it to become more negative. It limits the rate at which the SA node of the heart can go ahead and depolarize, which slows down the rate at which the electrical conduction takes place, which slows down the rate at which the heart will contract. The nicotinic side is all postganglionic, and it's all excitation. So what it's going to do is it's going to open up the channels, either calcium channels or sodium channels, leading to the excitation to take place. Now notice that we have the coupling within the muscarinic receptors, where we're going to have two distinct pathways of activation, either the IP3-DAG pathway or the cyclic AMP pathway, which we'll talk about in more detail when we get into the physiology of how receptors actually function. So let's take a look at the adrenergic receptors. There are two principal types of adrenergic receptors that we want to be aware of, and I'm going to go to the next slide here in a second and show you what they actually do in terms of their action. Notice that for both of them, they're going to be linked with the G-link protein, which means they're going to cause a change in metabolism. Notice that for the alpha-1, we have the IP3-DAG pathway, whereas for both the alpha-2 and then the beta-1 and beta-2, we get the cyclic AMP. These tend to be longer lasting in duration, and have a higher affinity for the receptors, which means that they're going to bind to the receptor and stay bound for longer periods of time, even though the neurotransmitter and the hormone being released have a very short half-life within the body. So the actions that we see. So let's take a look at the alpha-1. So actions of the alpha-1 at the vascular smooth muscle, it's going to cause contraction, which is going to cause constriction of the blood vessels. For the pupillary muscles of the eye, it's going to cause contraction, which is going to dilate the pupil. For the erector pili muscle, it's going to cause contraction, which can cause erection of the hair follicle, actually contraction of the skin around the hair, making the hair look like it's standing up. On the prostate gland, it's going to cause contraction of the myoepithelial tissue there, causing release of prostate secretions. In the heart, it's not going to necessarily cause depolarization to happen faster, but what it's going to do is it's going to accentuate the contraction strength of the muscle as it contracts down. But it's also going to lead to an increase of depolarization at the heart when it combines with the beta receptors. The alpha-2 receptors are going to be predominantly on platelets, causing aggregation. It's going to stimulate additional response of sympathetic signals by inhibiting the release of cholinergic terminals, particularly at the periphery. It's going to cause vascular smooth muscle to contract. It's going to inhibit lipolysis to a certain degree, because the problem is that while alpha-2s are going to inhibit, we have another type of adrenergic receptor, beta-3 receptors, which actually activates lipolysis. And one of the things that the sympathetic nervous system is going to do is it's going to provide a whole bunch of fuel sources coming into the system. For the beta-1, beta-1 is going to promote both an increased rate of contraction of the heart as well as an increased strength of the contraction of the heart. Whereas beta-2 receptors are going to predominantly cause relaxation of some smooth muscle. It's going to cause relaxation of smooth muscle in the vasculature in areas where we need to have more blood flow going to that area. It's also going to cause relaxation of the trachealis muscles, the muscles in the trachea, as well as the smooth muscles of the bronchs, allowing for an increased diameter of the trachea and the bronchioles. People who have asthma, we get a response within those tissues which causes constriction due to spasmic contraction. And so if you take a fast-acting inhaler, most of those fast-acting inhalers are beta-2 agonists, causing that muscle to relax. The problem is that since it's a beta-2 agonist, it's also going to attack the beta-1 receptors. And so we have to be very careful giving someone who's going to be highly active a fast-acting inhaler, because it can lead to tachycardic issues, which can become problematic for people who happen to have predisposed issues to left ventricular hypertrophication or sudden athlete death issues. In terms of the functionality of the autonomic nervous system, it's regulated by the hypothalamus and any cortical signals that registers stress. It cannot differentiate between an actual external stress and an internal stress. All it knows is stress. This is where if you happen to have any type of cognitive stress going on, it's going to trigger an autonomic response. It also has involvement within the limbic system, which is where we have to worry about the amygdala and hippocampal duality in terms of the ability to regulate stress and fear response. This is the system that comes into play with my inability to control and regulate overall function to stress. This is the division that comes into play that's going to allow me to survive a stress. It's involved with survival of the stress. It's not involved with adaptation to the stress. That's the endocrine system. So let's take a look at where these systems are coming from and where these systems are going to in terms of their breakdown. Now, the parasympathetic side we can break into a cervical region or a cranial region and then into the sacral region, which is why sometimes it's referred to as the cranial sacral nervous system, whereas the sympathetic system is coming from basically T1 to S2 nerve roots, forming what's referred to as the sympathetic trunk, which is on the posterior aspect of the thoracic region along the lateral margins of the vertebrae. So, the parasympathetic division. The principal ganglions that we see in the parasympathetic division are the ciliate ganglion, the parietal palatine ganglion with the submandibular ganglion, the otic ganglion, the cardiac plexus, pulmonary plexus, esophageal plexus, and abdominal plexus, and then the sacral plexus. So notice that we're coming from cranial nerves 3, 7, 9, and 10, and then coming from the sacral plexus. So bear that in mind when we look at the next slide in terms of what it's going to ultimately go to. So here is a schematic of the parasympathetic division. The most important of the division is going to be the division coming away from the vagus nerve, which is going to give rise to all of the innervations to the trachea, the bronchioles, the heart, the alimentary canal, the intestines and the stomach, as well as the liver and the gallbladder, the kidney, whereas the other branches within the parasympathetic are going to be controlling things like lacrimal secretions, constriction of the pupil, production of saliva and release of saliva, as well as genital ureteral responses leading to either micturition, release of urine, or psychosexual response. The sympathetic side is a little bit more diffuse. So what we end up having is we end up having ganglions and divisions coming from or making up this pathway, this nervous system. The preganglion is all coming to the sympathetic trunk, and then from the sympathetic trunk, we now have postganglions that are heading out into distinct chains, plexes, and then cords, which will form the nerves of the sympathetic nervous system. So the major sympathetic trunk ganglions we need to be aware of are the superior middle, the inferior cervical, the thoracic chain, the lumbar chain, and then the sacral chain. So from the cervical ganglion, we're going to get the cardiac plexus and the pulmonary plexus. You can take a wild guess where those will be going. From the thoracic chain, we get the greater, lesser, and least thoracic splanchnic nerve. From that, we get the greater thoracic, the ciliate ganglion, and from the lesser thoracic, we get the superior mesenteric ganglion. The ciliate ganglion and the mesenteric ganglion are going to be involved with regulation of the alimentary canal. From the lumbar chain, we get the lumbar splanchnic nerve, which is going to give rise to the inferior mesenteric ganglion. From the sacral chain, we get the sacral splanchnic nerve, which is going to give rise to the hypogastric plexus. Most of what those plexes and what those ganglions are going to do is regulate the rate at which materials are moving through the alimentary canal, as well as regulate the release of urine via micturition. It's this nervous system which causes the visceral response to stress that we sometimes associate with distinct sociological behaviors. So just like with the parasympathetic, take a look at the pathway as it comes out. So notice that we have the celiac ganglions heading out, where we're heading to the eye, to the lacrimal gland. We have the cardiac ganglions heading out to the heart. We have the pulmonary ganglions heading out to the trachea and the bronchioles. In the eye, this is going to cause an increase of lacrimal secretions as well as dilatation of the pupil. In the larynx and within the trachea and the bronchs, this is going to cause dilatation. In the heart, it's going to increase the rate of depolarization and the force of contraction. Most everywhere else, it's going to reduce functionality. The sympathetic nervous system is all about me being able to get away from whatever is stressing me. It's allowing me to run faster than you to get away from the bear because I cannot outrun the bear. This is the systems coming into play. It's going to make my skeletal muscles contract with more force. It's going to cause blood to shift and flow to areas of high demand away from areas of low demand, a phenomenon which we refer to as a cardiac shift. We'll get more detail into this when we look at stress response in physiology. But this system right here, both the parasympathetic and sympathetic, is highly integrated with the neuroendocrine system.